Imagine a really complex maxillofacial surgery. You are in the operating theater, the patient is draped, and the table is tilted sharply backward.
Right, maybe the head is extended, rotated 45 degrees or so to the left.
Exactly. And the surgeon, who is operating under intense magnification, needs to ask the assistant to pass an instrument towards the front of a specific delicate nerve.
But what does front actually mean in that precise moment?
Yeah, that is the problem. Does it mean towards the ceiling? Towards the patient's nose?
Yeah.
Or towards the surgeon's own chest?
In the chaotic three-dimensional reality of an operating theater, relying on everyday spatial terms is just a recipe for catastrophic error.
It really is. I mean, it leads straight to disorientation.
Absolutely. Without a rigid, universally agreed-upon spatial baseline, the communication you need to safely navigate the human body completely breaks down. You just cannot direct a surgical team that way.
No, and you cannot write a coherent pathology report either.
Quite right. And you certainly cannot interpret a diagnostic scan if your coordinate system shifts every single time the patient rolls over in the scanner.
And that spatial crisis really is exactly why we are starting here today. We are doing a deep dive into the foundational grammar of medical science.
Yes, acting as a companion synthesis to the anatomic concepts and the deep phase chapters from the textbook of head and neck anatomy by Hyatt and Gardner.
Exactly. And the objective for you listening today, whether you are a medical student just entering your clinical years, a surgical trainee, or maybe a clinician revising applied anatomy, the goal is not to passively review a glossary of terms.
No, absolutely not. I mean, you already know that anterior means front and posterior means back.
Right. We are way past that. Our mission is to build a really robust, dynamic, spatial, and functional mental model.
Because anatomy is not a static list of Latin names. It is an applied spatial science. It is the study of vital dynamic relationships.
We are going to explore how structure serves function and really how that structure dictates disease, intervention, and surgical outcome.
Spot on. When a clinician truly understands the structural relationship between, say, a vessel, a nerve, and a bone, they inevitably understand the functional purpose of that whole region.
And by extension, they can anticipate exactly what happens when trauma or disease or a surgical scalpel disrupts that architecture.
Precisely. So let us try to resolve that surgeon's dilemma from the beginning. We need our true north.
We need a universal anchor. Something that remains absolute regardless of the patient's physical orientation in the real world.
And in medicine, that anchor is the anatomic position. The text defines it as an erect body, facing forward, with the palms facing forward.
Every anatomical description, every single textbook diagram assumes this exact starting posture.
It is the absolute non-negotiable geometric baseline. And it is crucial to recognize that the anatomic position is not meant to represent a natural, relaxed human stance.
Right. Nobody naturally stands like that.
No, they do not. It is a highly engineered, theoretical posture designed specifically to eliminate structural ambiguity.
I mean, the erect body facing forward aspect is intuitive enough, but the palms facing forward element always requires active thought.
It does.
If you stand and just let your arms hang completely relaxed by your sides, your palms naturally turn inward, to face your thighs.
Or even slightly backward, yeah.
Right. So maintaining the palms facing forward requires an active muscular rotation. Why base a universal standard on an unnatural muscular contraction?
Think about the underlying skeletal architecture of the forearm. When your arms hang naturally in that relaxed, pronated state.
Okay, visualizing that.
The two bones of the forearm, the radius and the ulna, they actually cross over each other. They form an X.
Oh, wow. Yeah, they do.
Now, if you are an orthopedic surgeon trying to definitively map the complex relationship of the interosseous membrane, the deep muscles, and the neurovascular bundles winding through that space, a crisscrossed skeletal foundation is an absolute nightmare.
Because the reference points are quite literally
overlapping, exactly.
Yeah. But when you actively rotate the palms forward, the movement we call supination, what happens?
The radius and ulna uncross. They lie perfectly parallel to one another. The structural picture just opens right up.
So the anatomic position basically forces the anatomy into its most unobstructed, visible state, like resetting a complex machine to its factory defaults.
That is a brilliant analogy, yes.
So returning to our surgeon operating on the upside-down patient, when she says the incision needs to be on the anterior surface of the forearm, she is not talking about the surface currently facing the surgical lights.
No, she means the surface of the arm that would be facing forward if the patient were magically transported off the table and stood upright in that rigidly defined, supinated posture.
The terminology is forever locked to that theoretical true north.
Exactly. It ensures that anterior means the exact same thing to a radiologist reading a scan in a dark room as it does to the trauma surgeon manipulating the physical limb in the emergency department.
Having established that factory default, we can start to navigate the descriptive coordinates of the body. Now, we will bypass the really elementary definitions.
Right. We all know superior means headward and inferior means tailward, or cranial and caudal.
Yeah, exactly. Where this language gets genuinely fascinating and honestly occasionally frustrating for students is when we introduce the terms ventral and dorsal and rostral.
Aye.
Figure 2-2 in the text illustrates a human standing upright next to a quadruped, specifically a dog, and suddenly the terms shift.
They do, quite dramatically.
Why do embryologists and neuroanatomists abandon anterior and posterior in favor of ventral and dorsal?
Well, it really comes down to developmental history and the physical reality of the central nervous system.
Okay, break that down for us.
In an erect human, in the anatomic position, anterior and ventral are effectively synonymous. They both refer to the front of the belly and chest.
And posterior and dorsal both refer to the back.
Right. But the moment you drop to all fours, like the dog in the text's illustration, your orientation to gravity changes entirely.
Right. Your chest and belly, your anterior surface is now facing the floor. Your back is facing the ceiling.
Exactly. For a quadruped, anterior refers to the leading edge of the animal, the direction of travel towards the nose.
And posterior is towards the tail.
Quite right. But ventral always specifically denotes the belly surface, regardless of where the animal's walking or facing, and dorsal always denotes the surface of the spine.
Which raises a really obvious question for anyone listening. Why do human anatomists care about the spatial coordinates of a dog? We are studying the human map, right?
We care because a human embryo, in its critical early stages of forming the nervous system, does not resemble a miniature adult standing in the anatomic position at all.
What does it look like?
It is a curved, C-shaped tube. The neural tube, which will eventually become the brain and spinal cord, develops along the dorsal axis of this curved embryo.
So it's growing along the back of that C-curve.
Exactly. And as the embryo matures, the portion of the neural tube that becomes the brain undergoes massive complex folding. It bends sharply forward at what we call the cephalic flexure.
Oh, wow. So the physical structure of the nervous system is this continuous tube that essentially hinges 90 degrees on itself.
It does. It folds over like a garden hose. Now, if a neuroanatomist tries to use anterior to describe the front-facing aspect of the spinal cord and then traces that continuous tract up into the folded brain.
Oh, I see the problem. Anterior suddenly means something entirely different because the structure physically curled over.
It creates a complete linguistic paradox.
The coordinate system breaks because the map itself folded in half.
Precisely. But if they utilize ventral, meaning the aspect facing the belly or the inside of that developmental curve,
Right.
and dorsal, meaning the aspect facing the outer curve of the spine, those terms remain perfectly structurally consistent along the entire twisted length of the nervous system.
That makes perfect sense. And what about rostral?
Rostral, which literally means towards the beak or nose, provides an additional coordinate to navigate the extreme anterior poles of that folded brain. This vocabulary survives the complex morphogenesis of the fetus.
That is just a phenomenal demonstration of how medical language must adapt to biological reality.
It really is.
Now, let's look at another highly specialized adaptation of these coordinates. Because this text focuses heavily on the head and neck, and particularly the oral cavity, it introduces vocabulary uniquely tailored for dental and maxillofacial applications.
Yes, specifically the terms mesial and distal.
Exactly. How do these diverge from standard medial and lateral?
Well, standard medial and lateral rely on a single, straight, mid-sagittal plane dividing the entire body down the middle.
Right, a flat grid.
But the dental arch, the physical arrangement of the teeth in the maxilla and mandible, is a horseshoe-shaped curve.
It is basically a U shape.
Exactly. So if a clinician attempted to use a straight medial to describe a location on a tooth that is curving around the back of the jaw, the geometry simply fails.
You cannot easily apply a flat grid to a U-shaped structure.
You cannot. Therefore, dental anatomy establishes a specific, localized median plane of the face. It is an imaginary line passing precisely between the two central incisors, the very front teeth.
I always picture the dental arch as a curved row of houses situated on a cul-de-sac.
Oh, that is a great way to visualize it.
Yeah, and the absolute center of the cul-de-sac, the very middle of the turnaround, is that median plane between the central incisors.
It is a very accurate metaphor. So any movement along the curvature of the dental arch towards that central dividing line is defined as mesial.
And any movement along the curve away from that central line, heading posteriorly towards the throat, is distal.
Yes, exactly.
So if you are charting a specific cavity on a premolar and the decay is on the side of the tooth facing the front of the mouth, that is a mesial lesion.
Right.
If it is on the side facing the back molars, it is a distal lesion.
Spot on. It retains the general philosophical concept of distal, meaning further away from the origin, but the origin point has been distinctly redefined from the root of a limb to the median plane of the dental arch.
It allows for absolute precision when operating on a curved surface,
Yeah.
which is so vital in dentistry.
Absolutely vital.
Okay, so we have established our default position and our coordinates. To truly understand deep anatomy, we must understand how to slice the map.
Yes, we need to master the planes of reference.
And this is arguably the most critical skill for modern clinical practice, primarily because of diagnostic imaging, right?
Without a doubt. When you look at an MRI or a CT scan, you are not looking at a whole patient. You are looking at an isolated slice of data.
And if you do not instantly, intuitively understand the geometric plane of that specific slice, the data is not just useless, it is potentially dangerous.
Exactly. The textbook outlines 3 primary planes that construct a complete 3-dimensional Cartesian coordinate system for the human body.
Let's start with the central divider, the median or mid-sagittal plane. This is the vertical pane of glass dropping perfectly through the absolute center of the head, down through the sternum, dividing the body from anterior to posterior into right and left halves.
Yes. But the text includes a rather fascinating caveat about this plane.
Oh, what is that?
It notes that this plane divides the body into symmetric halves, except for certain areas of the viscera.
Ah, right. That caveat is a profound reminder that biological anatomy is not pristine geometry.
It really isn't. Somatically, on the outside, we exhibit beautiful bilateral symmetry, one arm on the left, one on the right.
But internally, the visceral architecture is entirely asymmetrical.
Exactly. The heart tilts prominently into the left hemithorax. The liver occupies a massive space in the right upper quadrant of the abdomen, while the spleen is tucked high on the left.
Even the lungs, right? The right lung has 3 lobes, but the left has only 2, just to accommodate the cardiac notch.
Quite right. So the mid-sagittal plane is a perfect concept that slices through a gloriously lopsided reality.
And understanding that asymmetry is vital. I mean, if a patient presents with situs inversus, where the visceral organs are mirrored.
Oh, yes. A surgeon mapping an appendectomy based on standard right-sided assumptions could face a critical surprise.
That would be terrifying. So any vertical plane that runs parallel to that unique central mid-sagittal plane moving out laterally to the left or the right is simply termed a sagittal plane.
Yes, exactly.
Next, we have the transverse or horizontal plane. This is the cross-section. It passes through the body at right angles to the sagittal planes, dividing the body into superior and inferior portions.
And this is the absolute bread and butter of axial CT scanning.
It is. But the viewing conventions can be tricky for students. When you view a transverse abdominal CT scan, what is the clinical convention?
The convention is that you are viewing the slice from the patient's feet, looking upwards towards their head.
Right. So the right side of the image actually displays the left side of the patient's body.
Exactly. Without a rock-solid understanding of the transverse plane and its clinical viewing conventions, you could easily misidentify the side of a pathology. You could literally operate on the wrong kidney.
Which is why mastering this spatial grammar is so critical. Finally, we have the coronal or frontal plane. This vertical pane of glass enters through the side of the shoulder, dividing the body into anterior and posterior sections, a front half and a back half.
And the clinical utility of the coronal plane is immense, particularly in head and neck imaging.
Give us an example.
Well, if an oral surgeon has evaluated the maxillary sinuses prior to a complex sinus lift and implant placement, a coronal scan provides the optimal view.
Why is that better than a transverse scan?
Because the coronal view allows the surgeon to assess the vertical thickness of the sinus floor and its relationship to the roots of the posterior teeth. A transverse slice just would not give the necessary vertical depth perspective.
Right, you need to see the height of the bone you were working with. So, with the language of spatial coordinates and reference planes established, The text challenges us to think about how we actually approach the study of the body.
Yes, there are multiple divisions of anatomy. They represent different magnifications and different timelines of the exact same physical structures.
Let's explore why these different lenses are clinically relevant.
The first division the text highlights is developmental anatomy, or human embryology.
Which, as we discussed with the nervous system, is not merely an academic history lesson.
No, it is the causal narrative for adult anatomy.
It really is the architectural time-lapse. I love the example of the adult recurrent laryngeal nerve. If you look at its path in an adult, it just seems utterly absurd.
It is a massive, inefficient detour.
I mean, it branches off the vagus nerve in the neck, dives all the way down into the thorax, loops under the aortic arch on the left side, and then travels all the way back up into the neck just to innervate the larynx.
It seems like a massive design flaw.
Right. But when you view that nerve through the lens of developmental anatomy, the absurdity vanishes.
Exactly. Because in the developing embryo, the nerve and the blood vessel it hooks under, which is the sixth branchial artery, start out high up in the cervical region right next to the larynx.
Oh, so they start right next to their target.
They do. But as the fetus develops, the heart descends into the thorax, and it drags that artery down with it.
And the nerve, which is caught under the artery, gets dragged down too, creating that massive loop.
Precisely. Embryology explains the why behind the structural quirks.
It also explains congenital variations. If a patient presents with a lateral neck cyst, understanding the embryological branchial clefts tells the surgeon exactly what embryonic tissue failed to obliterate.
Which predicts the cyst's likely depth and attachments. It's invaluable.
The next division is neuroanatomy.
Yes. The structural complexity, the extreme specialization of the tissue, and its profound functional significance really demand a dedicated field of study.
And then we shift magnification entirely to microscopic anatomy or histology.
This is zooming in way past the unaided eye.
It is understanding that a muscle's gross action is entirely dependent on the microscopic arrangement of its sarcomeres, or that the structural integrity of a blood vessel relies on the histologic layering of the tunica intima, media, and adventitia.
Quite right. Which brings us to the core focus of the text, macroscopic or gross anatomy.
The visible, tangible architecture. But here is where the text draws a massive line in the sand regarding the approach to gross anatomy. It contrasts systemic anatomy with regional anatomy.
Yes, this is a vital distinction.
Systemic anatomy studies the body one complete physiological system at a time. You study the entire muscular system from head to toe, then the entire cardiovascular system.
It feels very clean. It allows you to understand the isolated physiology of how a heart pumps or a muscle contracts.
But the text firmly rejects this approach for advanced study. Why?
Because the body does not exist in clean, isolated systems. The systemic approach is an artificial academic separation.
Right. If a head and neck surgeon makes an incision to remove a submandibular gland tumor, they do not just encounter the glandular system.
They encounter reality.
And reality is messy.
It is an incredibly dense, chaotic integration of systems. Regional anatomy, which is the strict philosophy of this textbook, takes a specific topographical area, like the neck, and demands that you study absolutely every structure within that space simultaneously.
Because if you try to study the head and neck systemically, it fails immediately. You cannot discuss the mandible without discussing the muscles that move it.
And you cannot discuss those muscles without mapping the specific branches of the trigeminal nerve that fire them.
Exactly. And you cannot discuss the nerve without tracking the maxillary artery winding through the exact same physical space.
Regional anatomy forces you to understand structural relationships. It teaches you that a tumor expanding in the parotid gland will likely compress the facial nerve.
Not because the nerve and gland share a physiological system, but because they share the exact same regional real estate.
The nerve literally pierces through the substance of the gland. Regional anatomy is the anatomy of surgical and clinical reality.
Okay, to truly test this regional approach, we need to apply our new spatial vocabulary to one of the most notoriously complex territories in the human map, the deep face.
Yes, this is a masterpiece of biological engineering.
It is an area where bone, heavy muscle, intricate wiring, and high-pressure plumbing are all woven together in an impossibly tight space, all to facilitate one primary mechanical act: mastication, chewing.
We must first establish the geographical boundaries. The term deep face generally refers to the highly irregular hidden spaces situated deep to meaning internal to the ramus of the mandible and the zygomatic arch, which is the cheekbone.
The text subdivides this lateral aspect of the head into two distinct fossa, the temporal fossa and the infratemporal fossa.
And a fossa is simply a shallow depression or hollow.
Right. I find it really helpful to conceptualize the thigh head as a two-story structure. The temporal fossa is the attic.
The attic is a highly accurate spatial metaphor, actually. The temporal fossa is that broad, relatively flat region on the side of the skull, superior to the ear and extending upward.
It is the area we colloquially call the temple.
Exactly. And its defining feature is that it is almost entirely occupied by one massive fan-shaped muscle, the temporalis.
So the muscle fills the attic, and its fibers converge downwards, funneling through a narrow gap just deep to the zygomatic arch.
It essentially passes through the floorboards of the attic to attach to the coronoid process of the mandible down below.
And the space it reaches below is our second region, the infratemporal fossa. If the temporal fossa is the attic, the infratemporal fossa is the basement mechanical room.
Yes. The text describes it as the region inferior and deep to the zygomatic arch in the mandible.
It is not a neat walled-off box like the cranial vault, is it?
Oh, not at all. It is an irregularly shaped, incredibly dense thoroughfare.
What exactly constitutes the heavy machinery in this basement?
Well, primarily it serves as the staging ground for the muscles of mastication. It contains the origins and insertions of the pterygoid muscles, but it is also a vital neurovascular junction box. It houses the maxillary artery, which is a major terminal branch of the external carotid, and its chaotic web of branches supplying the deep facial structures, the nasal cavity, and the teeth.
It also contains the pterygoid venous plexus, right?
Yes, a dense, tangled network of veins. And critically, from a clinical perspective, these veins in the head and neck are largely valveless.
Wait, valveless, so blood can flow in either direction?
Exactly. Blood can flow in multiple directions depending on pressure gradients.
Wow. What does that mean clinically?
It means an infection originating in the deep face, or even from a severely abscessed upper tooth, can track backwards through this plexus directly into the cavernous sinus inside the skull.
Oh, that sounds incredibly dangerous.
It is. Understanding this regional venous architecture is essential for recognizing how a simple dental infection can become a lethal intracranial complication.
And finally, weaving through all of this muscle and vasculature in the infratemporal basement is the complex branching network of the mandibular division of the trigeminal nerve, or V3.
Yes, so let's focus on the primary mechanical function housed within these fossae, mastication.
The text identifies 4 bilateral muscles dedicated to moving the mandible about the temporomandibular joint, or TMJ.
This movement facilitates chewing, swallowing, and phonation.
Now, the spatial rule the text establishes is that all of these muscles originate in either the temporal or infratemporal fossae, with one distinct exception. Let's outline the 4 muscles first: the temporalis, the masseter, the medial pterygoid, and the lateral pterygoid.
Right, and the exception to the spatial rule is the masseter.
Because the temporalis occupies the temporal fossa.
And the medial and lateral pterygoids are buried deep within the infratemporal fossa.
But the masseter sits superficially.
It does. It originates from the inferior border of the zygomatic arch and drapes over the outside, the lateral surface of the ramus of the mandible.
It is that powerful, thick muscle you palpate on the angle of your jaw when you clench your teeth. If you just reach up and feel your jaw right now, that is the masseter.
Exactly. Now, the text provides a fascinating functional categorization of these 4 muscles, dividing them based on their action upon the jaw. We have elevators, and we have a depressor.
Applying our anatomic concepts, elevating the jaw means moving it superiorly, closing the mouth. Depressing the jaw means moving it inferiorly, opening the mouth.
The text lists the elevators as the masseter, the temporalis, and the medial pterygoid. 3 separate, massive, multi-pennate muscles completely dedicated to closing the jaw.
And the sole depressor in this primary group is the lateral pterygoid, whose job is to initiate the opening of the jaw.
The lateral pterygoid also protrudes the jaw, pulling it forward, and allows for the side-to-side grinding motion essential for breaking down food, but its primary vertical action is depression.
From an engineering perspective, this represents a staggering structural asymmetry, a 3-to-1 ratio favoring closure.
It is quite dramatic.
If we look at the elbow joint, we see the biceps acting to flex it and the triceps acting to extend it. The muscular volume is relatively balanced because the required force is similar in both directions. Why does the temporomandibular joint feature such a massive over-engineering of the closing mechanism?
It perfectly illustrates our core principle: structure in service of function. To understand the anatomy, you must analyze the physics of the task.
Okay, let's break down the physics. Consider the biomechanics of opening the jaw. What forces are acting against you?
Very few, actually. Gravity actually assists in depressing the mandible.
Right, your jaw naturally wants to drop open if you relax completely.
Exactly. When you actively open your mouth to speak or to take a bite, you are merely overcoming the slight elastic resistance of the surrounding soft tissues and moving the relatively light mass of the bone itself.
So it is a low-resistance task?
Yes. The lateral pterygoid, aided by smaller accessory muscles in the neck like the digastric, is more than sufficient for this low-resistance task.
But closing the jaw during mastication is a completely different physical event.
It is an event that requires immense, sustained, destructive force.
Because you are crushing things.
Right. The TMJ functions as a Class 3 lever system.
Like a pair of tweezers or a staple remover.
Yes. The joint is the fulcrum, the muscle attachments provide the effort, and the food between the teeth is the load. Because the teeth, the load, are situated further from the fulcrum than the muscle attachments. The effort, the jaw acts at a mechanical disadvantage.
Meaning you have to generate a disproportionately massive amount of muscular force close to the joint just to achieve a strong crushing force out at the incisors or molars.
Precisely. To crush hard food, break down tough plant fibers, or shear meat, the biological engine must be incredibly powerful.
That is why evolution provided 3 heavy-duty elevators. The masseter delivers raw, brute crushing force.
And the temporalis, pulling upward and backward from its broad attic origin, provides powerful elevation and retraction, snapping the jaw shut.
And the medial pterygoid.
The medial pterygoid originates deep in the infratemporal fossa and attaches to the medial or inside surface of the angle of the mandible. It effectively mirrors the masseter, which sits on the outside.
Oh, so they sandwich the jawbone.
Exactly. Together, they form a highly efficient muscular sling that pulls the jaw forcefully upward and slightly forward. The 3-to-1 imbalance is not a design flaw at all.
It is a perfectly tuned mechanical response to the physical demands of eating.
Yes.
But, heavy machinery is useless without a control system. It needs to receive signals from the central nervous system. In the deep face, that wiring harness is the mandibular division of the trigeminal nerve.
Cranial nerve V, the trigeminal, is the primary sensory nerve of the entire face. It has 3 major divisions: ophthalmic, maxillary, and mandibular.
And mandibular division, or V3, is unique because it is a mixed nerve. It carries both sensory fibers and, crucially, motor fibers.
The text highlights that this specific division provides the sole motor innervation to all 4 of the muscles of mastication.
It acts as the absolute command center for jaw movement.
It does. If V3 is severed or severely damaged due to trauma or a tumor, the result is flaccid paralysis of the masticatory muscles on that side of the face.
What does that look like clinically?
Well, the jaw will actually deviate towards the paralyzed side when opened.
Wait, towards the paralyzed side? Why?
Because of the unopposed action of the healthy lateral pterygoid on the opposite side, which pushes the jaw forward and across.
Oh, that makes perfect sense based on the mechanics. Now, the regional routing of this nerve is a masterpiece of complex spatial navigation. It exits the cranial cavity through an opening called the foramen ovale, dropping straight down through the roof of our basement mechanical room, the infratemporal fossa.
And once inside that dense, crowded space, it immediately begins branching. It must weave between the bellies of the pterygoid muscles, navigate around the pulsating maxillary artery and the venous plexus to reach its targets.
It sends motor branches to the muscles, but it also sends a major sensory branch, the inferior alveolar nerve, diving directly into a canal inside the mandible bone itself to provide sensation to the lower teeth.
Yes, and this is exactly what a dentist targets when they perform a lower jaw nerve block.
They are trying to inject anesthetic into the precise space in the infratemporal fossa where that specific branch of V3 enters the bone.
And that leads us perfectly into the most crucial philosophical shift required of an anatomy student, which is addressed in the clinical correlations section of the text.
Because if a dentist uses textbook measurements to inject that anesthetic, and the patient's nerve is situated just 3 millimeters to the left, the block fails. The patient feels everything.
The text delivers a stark, humbling warning. A student of anatomy must learn early that anatomic variation is frequently the rule rather than the exception.
It is a sentence that just completely shatters the illusion of those pristine, color-coded textbook diagrams.
It really does. The bodies of living patients and the cadavers encountered in the dissection lab rarely conform perfectly to the idealized map.
But if variation is the rule, does that mean the map is entirely untrustworthy? I mean, how can you learn anything if it's all random?
Well, it is not all random. The text provides parameters, distinguishing between what is generally stable and what is chaotic. It points out that the total number of bones is remarkably constant. We generally all have 206 bones.
So the macro-level skeletal framework is a reliable foundation.
Yes. However, as you zoom in on those bones, the fine details vary wildly.
Like the bony processes.
Exactly. The ridges, tubercles, and spines where muscles and ligaments attach are shaped entirely by the physical stresses placed upon them during a person's life.
So a professional weightlifter will have vastly more prominent bony processes than a sedentary individual because the bone remodels in response to the muscular pull.
Quite right.
What about the soft tissues?
This is where the textbook map becomes merely a suggestion. Muscle bellies might be split, absent, or have accessory slips attaching to unusual locations. But the true chaos lies in the neurovascular system, the wiring and the pining.
Why is the vascular system so unpredictable?
It stems from embryology. During fetal development, angiogenesis, the creation of blood vessels, starts as a massive, somewhat random capillary network.
Just a web of tiny vessels.
Right. The specific pathways that eventually become the major, named arteries, are simply the channels that happen to receive the highest flow dynamics during development.
It is like water carving a path down a hillside. It generally flows in the same direction, but the exact microchannels it cuts will be slightly different on every single hill.
That is exactly it. So the maxillary artery in the infratemporal fossa might run superficial to the lateral pterygoid muscle in one patient and dive deep to it in another, simply based on how the fetal blood flow carved the path.
The text emphasizes that arterial branching patterns are highly variable. The exact point where an artery bifurcates, or the specific sequence of branches it gives off, is rarely identical between two patients.
Which presents a terrifying scenario for a surgeon. If the map is fundamentally unreliable, how do you navigate without cutting a vital structure?
The text argues that true anatomical mastery is not rote memorization of one static pattern. It is the ability to logically deduce the significance of variations in real time.
Yes. Let's use a city traffic analogy.
Okay, I love a good analogy.
A delivery driver might memorize the primary route across town. But if a major arterial road is blocked due to an accident, rote memorization fails. They are stuck.
Right.
However, a driver who deeply understands the logic of the city's grid, who knows where the traffic ultimately needs to flow, can immediately identify which side streets, which collateral routes can handle the diversion.
That is a brilliant clinical translation. Surgeons navigate variation using the exact same deductive logic. They don't just memorize where the textbook says the artery should be, they memorize the target the artery must supply.
Exactly. If a surgeon operating in the neck encounters a highly unusual branching pattern off the external carotid artery, they do not panic. They trace the variant vessel.
If they know the thyroid gland requires a massive blood supply, and this variant artery is heading toward the thyroid, they logically deduce its function and preserve it, regardless of its unexpected origin.
Making rational decisions in surgery depends entirely on extrapolating the effects of the variation. If you ligate or tie off an unusual vessel, you must know if the patient has sufficient collateral circulation to keep the target tissue alive.
You must understand the grid.
This is why the regional approach, combined with the philosophy of structure serving function, is the only way to safely practice medicine. If you know what a structure must do and where it must go, you can identify it even when it hides.
We have covered a tremendous amount of ground today. Let's synthesize the core concepts before we test our application of this knowledge.
The foundational takeaway is that anatomy is an applied spatial language. It demands a universal reference, the anatomic position, to eliminate ambiguity and ensure precise clinical communication.
And we must study regions like the head and neck using a regional approach. We cannot isolate systems. We must embrace the chaotic, interconnected reality of bones, muscles, nerves, and vessels sharing the exact same physical territory.
We observe this integration in the deep face, defining the temporal and infratemporal fossae as the vital architectural spaces, the attic and the basement, housing the heavy machinery of mastication and the complex wiring of the mandibular nerve.
We saw how structure is shaped by function, analyzing the physics of the temporomandibular joint lever system to explain why 3 massive elevator muscles are required to crush food, while only 1 depressor is needed to open the mouth.
And crucially, we learn to expect variation. The human body is a biological reality, not a geometric schematic. Clinicians must cultivate the deductive reasoning required to interpret unique anatomical pathways safely.
Now, let's put this into practice with some learning reinforcement. We will work through 7 single best answer questions derived directly from the text's core concepts. I will set up the clinical or theoretical scenario. I will pause to let you, the listener, lock in your answer, and then the expert will break down the reasoning.
No good.
Question 1, focusing on spatial language. Imagine you are an orthopedic surgeon repairing a complex fracture of the forearm. To communicate the position of a bone fragment relative to the standard anatomic position, how must you assume the patient's palms are orientated? Is it A, facing the sides of the body, B, facing backwards, C, facing forward, or D, resting on the anterior thighs?
The correct answer is C, facing forward.
Yeah.
As we discussed, this supinated position uncrosses the radius and ulna, creating the universal, unobstructed geometric baseline required for precise spatial description.
Question 2, exploring dental terms. You are charting a patient's U-shaped dental arch. You locate a concarious lesion on a tooth that is situated on the surface, curving closer towards the median plane of the face, the line between the central incisors. Which specific term describes this location? Is it A, distal, B, proximal, C, superficial, or D, mesial?
The correct answer is D, mesial. This specialized term adapts linear coordinates to a curved structure. Distal would mean further away along the arch. Proximal is a term generally reserved for describing positions relative to the root of a limb.
Brilliant. Question 3, testing the planes of reference. A radiologist is reviewing a stand that provides a view dividing the patient's head into anterior and posterior sections, allowing clear visualizing of the vertical depth of the maxillary sinuses. Which plane was used? Is it A, the sagittal plane, B, the frontal or coronal plane, C, the transverse plane, or D, mid-sagittal plane?
The correct answer is B, the frontal or coronal plane. The pane of glass enters through the side of the shoulder. The sagittal and mid-sagittal planes divide the body into left and right, while the transverse plane creates superior and inferior cross-sections.
Spot on. Question 4, analyzing the muscles of mastication. A patient suffers nerve damage and loses the ability to initiate the opening of their jaw against slight resistance. Which specific muscle, acting as the sole depressor in its group, is likely compromised? Is it A, the masseter, B, the temporalis, C, the medial pterygoid, or D, the lateral pterygoid?
The correct answer is D, the lateral pterygoid. The masseter, temporalis, and medial pterygoid are all powerful elevators, designed to overcome the mechanical disadvantage of the TMJ lever system to crush food.
Question 5, applying regional anatomy to the deep face. A severe infection has filled both the temporal and infratemporal fossa. Which of the 4 muscles of mastication would be least directly affected by the physical swelling within these specific deep spaces? Is it A, the masseter, B, the temporalis, C, the medial pterygoid, or D, the lateral pterygoid?
The correct answer is A, the masseter. The text defines the temporal and infratemporal fossae as the origin points for all the masticatory muscles except the masseter, which is situated more superficially on the lateral aspect of the zygomatic arch and mandible.
Question 6, integrating neuroanatomy. A tumor expanding in the infratemporal fossa is compressing a major nerve, resulting in flaccid paralysis of the jaw muscles. Which structure provides this vital motor innervation? Is it A, the facial nerve, B, the maxillary division of the trigeminal nerve, C, the mandibular division of the trigeminal nerve, or D, the pterygoid venous plexus?
The correct answer is C, the mandibular division of the trigeminal nerve, or V3. This mixed nerve navigates the dense basement of the infratemporal fossa to deliver motor commands, while also providing sensory branches to the lower jaw and side of the head.
Finally, question 7, addressing clinical variation. A surgical textbook details the exact branching pattern of the maxillary artery. Based on the realities of anatomical variation, in which of the following structures is a medical student least likely to observe significant deviation from the textbook norm? Is it A, the branching patterns of nerves, B, the origins and insertions of muscles, C, the sources of blood supply, or D, the total number of bones?
The correct answer is D, the total number of bones. While variations in embryologically driven blood supply, nerve routing, and stress-adapted muscular attachments are incredibly common, the macro-level skeletal framework, the baseline count of 206 bones, shows minimal variation.
As we conclude this deep dive, I want to leave you with a provocative philosophical question that builds on everything we've discussed regarding anatomical variation. We established that variation is the rule, a natural outcome of embryological development and mechanical stress.
We all possess slightly unique maps.
Exactly. But in clinical medicine, a massive critical decision relies on distinguishing a variation from a pathology.
Yes, that is the crux of it.
If an artery takes a highly unusual route but successfully delivers adequate blood to its target, that is simply a variation. But what if that unusual routing causes the artery to be slightly compressed only when the patient turns their head to the extreme left?
Yeah.
What if it functions perfectly 99% of the time but fails under physiological stress? At what precise moment does a structural difference cease being a uniquely beautiful feature of an individual's biology and transition into a functional defect requiring surgical intervention?
That is the real test.
How does a master clinician draw that invisible, life-altering line between a harmless difference and a disease state? It is a question that requires far more than rote anatomical memorization. It demands profound clinical wisdom. Here are the details of this episode.
Anatomic concepts. Byline. To understand the body, one must first learn the language in which it is described.